Assalamu alaikum wa rahmatullahi wa barakatuh. Dear colleagues and friends, hope you are all doing well and you are safe. This week's discussion will be about the audit stations, how to proceed and how to approach different types of stations that includes the audit topic. Actually, this is one of the easiest and the difficult station in the same time. It will be very easy for the UK candidates because audit is part of their clinical practice, but it will be very difficult for the overseas candidates because they are not used to it. They are not familiar of the steps of the audit cycle. So today I will try my best to make it easy. I will put all the questions that you may be asked during the station. So this station, it may come as simulated colleague task for teaching your junior trainee how to do the steps of the audit cycle. So you will define for him what's audit, you will explain the component of the audit cycle, and you will apply the principles of the audit cycle to the requested task which was given to you, and you will answer his concerns or his question. The second type of audit station, it may be a critical appraisal of a previously done audit, or to complete the cycle of a previous audit by doing re-auditing. So it's important to know the audit. To make it easier today, I will make it in the format of questions and answers. So I will give all the possible questions and how to answer them in a simple way. So the first question that you may find in the exam, what is the definition of an audit? So the audit is a quality improvement process that aims to improve the patient care and outcome. It is done by measuring our current practice against explicit criteria and standards and implementation of a change. So there are three parts here of the definition. The first part, it is a quality improvement process. The second part, it is done by measuring our current practice against explicit criteria and standards. The third part, implementation of a change that aims to improve the patient care and outcome. The changes to be implemented may be implemented on individual, on team, or on service level. It is very important to correct the misunderstanding that an audit is a blaming or fault-finding process. Audit is a way to correct the current practice. It is not a blaming or fault-finding process. So this is the answer of the first question. What is the definition of an audit? The second question will be, what is the difference between research and an audit? To make it simple, research is concerned with discovering the right thing to do. It is discovering a new knowledge. But audit is concerned with ensuring that the right thing is done. So audit is concerned with ensuring that the discovered new knowledge is applied now. So this is the easiest way to discriminate or to differentiate between research and an audit. But there are many differences between the research and the audit. These differences include research creates a new knowledge, but the clinical audit tells us if we are following the current best practice or no. Second, very important point, that research involves trying a new treatment on the patients, which will never occur in audit, because audit never involves patients trying a new treatment method. So research may involve a degree of experimentation, but clinical audit never involves anything new happening to the patient. Research may allocate the patient into different treatment groups, but the clinical audit will never classify the patient into different treatment groups. The result of the research will be generalizable. It will be distributed all over the trusts, but the clinical audit results will be applicable only within the local settings. The final point, research needs ethical approval, which is not the case in all audits. Most of the audits will need an ethical approval from the ethical committee in case you need an access to the patient data. So all researches needs an ethical approval, but not all audits needs an ethical approval. So now we answered the first two questions. What is the definition of an audit? And what is the difference between research and audit? The third questions may be what can be audited. So we have three things in our service that can be audited. The first thing is the structure of the service itself. The second will be the process of the service. And the third will be the outcome of the service. Let's go one by one. Number one is the how to audit the structure of the service. To make it easier, let's take an example. If the evidence showed that patients who are transferred with abnormal cervical smear to colposcopy will have a better outcome, or patients with ovarian cancer, they will have better outcome if they are operated by a trained gynecologist within multidisciplinary team. So the audit here will be about the referral and the management of patients with ovarian cancer or abnormal cervical smear. So this is the first part to be audited, the structure of the service itself. And this part involves all the healthcare providers, and it also involves the patients. We have to know the problem from the patient perspectives. So this is the first thing to be audited, which is the structure of the service. The second thing to be audited is the process of the service itself. Actually, this part is very important because the clinical practice that has been evaluated in research and shown to have an influence on outcome. To make it easier, let's take another example. If the evidence shows that the use of antenatal corticosteroids will improve the perinatal outcome. So how to audit this? We will evaluate the process here by measuring the proportion of women who received antenatal corticosteroids. Actually, measuring the process of care has some advantages. Why? Because it gives you a direct measure of the quality of care. It will need smaller samples, so it can occur more frequently. It will need less cost because smaller samples and smaller audits are needed, and the findings here are easier to interpret. So now we measured the structure of the service and the process of the service. The last thing that can be audited is the outcome. Usually, this is the first thing to be in your mind if you are measuring the service or the outcome of the service. This outcome may be physical or behavioral. For example, outcome may be the health status of the patient is dead or alive, the cure following the surgery, and we can also measure the patient satisfaction. These all are types of outcome. This outcome can be desirable or undesirable. Desirable, for example, improvement in the patient condition or quality of life, and undesirable outcome like adverse effects or complications of treatment. The outcome measures has limitations, which include they cannot be a direct measure of the care provided because there are many other factors that may contribute to eventual outcome. Number two, not all the patients who experience substandard care will have poor outcomes. Some of them will be lucky, in spite of the substandard care, they will have good outcome. Number three of the limitations, outcomes may be delayed and adverse effects occur less frequently, so we will need larger samples here. And also, the research evidence about the impact of outcome is limited. So these are the limitations of measuring the outcome. But despite all of these difficulties associated with the interpretation of the outcome, still the outcome in the form of morbidity and mortality are very important to measure the quality of care after regular monitoring of the outcome. So this is the answer of the third question here. What can be audited? Either the structure of the service, the process of the service itself, or the outcome of the service. So now we answered 3 questions. The first, what was the definition of an audit? The second, what is the difference of audit and research? The third, what can be audited? Now the fourth question, which is the main bulk of our station today, is the audit cycle. What are the components of the audit cycle? Simply, there are 5 steps of the audit cycle to be completed. The first step is to select the topic or to identify the problem. The second step is to set the criteria and standards. The third step will be data management. And data management will be actually in 2 steps. The first is to collect the data or to measure your current practice. The second step is how to do data analysis. Data analysis means we are comparing our current practice against the set criteria and standards. The fourth step of the audit cycle will be what are the recommendations and the changes. This recommendation and changes has to be implemented, and then we have to agree on measures to monitor these changes. The final step in the audit cycle to close the cycle will be re-audit, or the second data collection after a suitable time that has to be detected from the beginning. So these are the 5 steps of the audit cycle. We will go through the steps one by one. The first step in the audit cycle is to select a topic or to identify the problem. This step, it includes many parts. The first part is the choice of the topic itself, and you have to address the aim of this topic, and you have to take approval from the audit department if needed, as we said before, if there is need to access the patient details. And finally, you have to set an audit team. So what are the criteria of the topic to be audited? The topic has to be a common health concern with high rates of morbidity and mortality, and there should be a good research evidence available to compare your current practice against the evidence which is available. So these are the criteria. It may be a question. What are the criteria of a topic to be chosen for an audit? It has to be a common health concern, high rates of morbidity and mortality, and there is good research evidence available for this topic. Another question, what are the sources of the topic? You can have the topic from the maternity dashboard, where you find that there is an amber color or red color, means you have a problem with this part of your practice, so you can take it as a topic for audit. Another source is from the new guidelines. For example, there is a new guideline which has published since few days about the use of corticosteroids in preterm labor. So after this publication, we need to do an audit after some time from the publication to see if we are following the new guidelines or no. So either from the maternity dashboard or from the new guidelines. Also, you can identify a problem from reviewing any significant or repeat incidents that happen. So we'll take this incident as a topic for the audit we will do. We can take it also from the patient complaints, or we can take it from unsatisfactory reports from the clinical quality control department. So this is an answer for this question. What is the source of the topic you will take for an audit? Maybe from the maternity dashboard, from new guidelines, from the incidents that are repeated or significant, from the patient complaints, or from the unsatisfactory reports of quality control department. The next point, the aim of your topic. As a general, a key consideration to answer this is the aim, how we will use the result of the audit to change or to improve our practice. So the aim is to change or improve our practice. After this, we'll go to the next step, which is to get an ethical approval. We will need an ethical approval if we need to gain access to the patient notes. Not all audits will need an ethical approval. Only audits that you need to gain access to the patient notes will need an ethical approval from the audit department. Then you will set up the team. Who is involved in the team? All the healthcare professionals should be involved in the team, including people to collect the data. You may need an IT staff for data management. Involve all the stakeholders under the lead of the consultant who is doing the audit. Another question, what about the cost? What about the funding? So the fund will cover the central cost, the data analysis, and benchmarking, but this funding will not cover the local data collection. So this is the first step of the audit cycle, is to select the topic. You have to mention some points under this part, including the criteria of the topic to be audited, from where or from which source you will choose your topic, what is the aim of the topic, if you are going to get an ethical approval or no, who are the people who will be involved in the team, and the fund will cover the cost or it will not. So this is the first step. The second step of the audit cycle is to set explicit criteria and standards. Here comes a question. What are the sources of the criteria and standards? The sources here will be from the evidence-based guidelines or from local agreed policy. So these are the sources of the criteria and the standard, either evidence-based guidelines or local agreed policy. Now, what is the definition of criteria? What's criterion-based audit? The criteria means the reference point against which your current practice is measured. So let's take an example here. For example, we will take the cesarean section. The criteria here is that thromboprophylaxis strategy should be part of the management of women delivered by cesarean section. So this is the criteria. What is the difference between criteria and the standard? The standard means a percentage, the percentage of events that should comply with the criteria. So if we'll go back to the same example, the criteria here is the thromboprophylaxis strategy that will be a part in the management of women delivered by cesarean section. So what is the standard here? The standard is the percentage of women who received the thromboprophylaxis after cesarean section. So the criteria is the reference point, while the standard is the percentage of those who comply to the criteria. Another definition, which you will hear a lot during the audit, is benchmarking. What's the definition of benchmarking? The benchmarking is to define a level of care. You have to define a goal to be attained. Why we are doing benchmarking? We are doing it to avoid over or underestimation of the problem. So you will avoid setting unnecessarily low or unrealistic high target level of performance. So these are very important definitions you should know. What is the definition of criteria? It is the reference point. What is the definition of standard? It is the percentage of those who reach the criterion, and the benchmarking is to define a realistic goal to be attained. From where you will get the criteria and the standards, from the evidence-based guidelines or from local agreed policy. So this is the second step in the audit cycle. So the first step is to select the topic or to identify the problem. And the second step is to set explicit criteria and standards. The third step in the audit cycle is to collect the data. And data collection is a way to measure your current practice. But there is a problem in the data collection, which is the confidentiality of the patient. So if you are going to access the patient notes, you have to take approval from the ethical committee. And you should follow the principles of Data Protection Act and the Caldecott principles. So what is the Data Protection Act and what are the 6 Caldecott principles you have to follow? First, the Data Protection Act. What is the Data Protection Act? It is a law that it is an offense to collect any personal details about the patient without their consent. Details that are identifiable, potentially identifiable for any patient, this is an offense to collect these data without the patient consent. To overcome this point, clinical audit now is considered a part of the direct patient care. So the consent for the use of the data is now considered as a part of the consent to the treatment, but you should inform the patient that their data may be used in this way. So this is the first part, which is a Data Protection Act. It is an offense to collect any details about the patient without their consent. So to overcome this point, now the consent for audit or to use the patient details is considered as a part of the direct care of the patient. So it is part of the consent, provided that you inform the patient. Now, the second part, which is the Caldecott principles. What are the 6 Caldecott principles? If you need to access the patient notes, you have to justify your purpose to an appropriate guardian. And you will not use any identifiable information unless it is absolutely necessary. When you use the data, use the minimum necessary patient identifiable information. Access to the identifiable information should be on the base of a strict need to know. So if you will have an access to any identifiable information, it should be on a strict need to know base. All the stuff that will be included in the audit should be aware of their responsibilities to respect the patient confidentiality. All the members should understand and comply with the law. So these are the 6 Caldecott principles, and this is the Data Protection Act you should know during data collection to measure your current practice. Now, how to collect the data? First step, what are the sources of the data? The sources include routinely collected data like the birth registers, and this needs a minimum effort because it is already done and it's already available. The second part is to review the clinical records, and the third source, it may be from observation or questionnaires that may be done for the patient or to the staff themselves. So this is the answer of the question, what are the sources of the data? The second is how to collect the data, either prospective or retrospective. Each one has its pros and cons. So the retrospective, which is the more common, it is easier, less time consuming, and less cost. But it has some advantages that by the retrospective way, some data may be missing, and this is a major drawback of the retrospective way. The second way of collecting the data is the prospective way. The advantage, it can lower the chance of missing data. But the disadvantage takes more time, more cost, and there may be observational bias. Why? Because there is tendency of the people to change their behavior or attitude when they know that they are under observation. So this is a way how to collect the data, either prospective or retrospective. Another question, who will collect the data? The answer here will be, it depends. If it is a small audit project, only the principal investigators will go through the clinical notes of the patient. But in large audit, like prospective audits, all the people involved in the audit can have an access to the patient, and they may need support from the audit support staff. So who will collect the data? It depends if it is a small audit project or large audit project. If it is a small, only the principal investigators. If it is large, all the healthcare providers, and with support from the audit department. Coming to the next point, which is the data analysis. Data analysis here, we are comparing our practice against the standard care. So the data includes 2 points. The first part is data collection, which means we are measuring our current practice. The second part of the data is data analysis or data management, where we are comparing our practice against the standard. So, sample size here, it is very important. You may be asked, what is the proper sample size and how can we detect the sample size? As a general rule, sample size calculation is necessary to ensure the audit is large enough to detect any significant difference between the groups. So, if the sample size is large, you can detect the difference easily. But if the sample size is small, the significance of the difference will not make a big deal. So, as a general rule, again, 50 or more cases will have a good reflection about the activity of the unit. At least 20 cases for the audit to be reliable. So again, the least number is 20, 50 or more will give a good reflection, but not less than 20. How can you detect the sample size? The sample size can be detected by one of 2 ways. Either you will detect the number of the cases from the beginning of the audit or from your study, or you can detect the sample size by detecting the duration of the study. So I will do my study between January and December, and I will take all the collected cases between January and December. So the sample size will not be detected from the beginning. But if you will use the number from the beginning, you are setting the number from the start. So either sample size can be detected by the number of cases to be reviewed or by the duration of the study. The least acceptable number is 20. For the audit to be reliable, 50 or more cases will give reflection about the activity of the unit. Another question, what about the performer? So the performer, it will be on a Microsoft Excel sheet or Microsoft Access database. The performer should be simple, containing only the necessary data or information. It has to be simple as much as possible. For example, in cases of shoulder dystocia, this is an example of a performer for data collection. So, very easy way. You are asking if the McRobert technique was done as the first technique in management, if the pediatrician was present at birth, if the baby was examined after delivery, if there was documentation and incident reporting, you will say yes or no. Very easy to collect the data and to answer the questions in the performance. Then after collecting the data, you will go to the data analysis or interpretation. The data analysis or interpretation can be quantitative, which means what we are actually doing, or qualitative, which answering why we are not achieving the standard. So the data analysis is either quantitative or qualitative. Here, this is the performer after analyzing the data. So, for example, the MRCOG technique done in our service in 90% of the cases, but the national standard that the MRCOG technique has to be done in 100% of the cases as the first maneuver. So your target here is not met and the outcome is not met in this case. The pediatrician present at birth is present in 98% in our service, but the national standard is 100%, so the outcome is not met. So this is an example of the performer and how to analyze the data on the performer. After analysis, you will come out with recommendations. So this recommendation has to be presented or disseminated to the group, to all the healthcare providers. So you should ensure that it reaches to everyone in the department or in the trust you are working in. So you should arrange a meeting. You should do good notification to ensure good attendance using emails, letters, or brochures. The meeting has to include all the people involved in the management of babies with shoulder dystocia. So it means the juniors, the seniors, the consultants, the midwives, the coordinating midwives, all the stakeholders should be involved in the meeting. During the meeting, it's better to use graphic presentations and charts to make it easier to be understandable. It should be in a friendly atmosphere, avoid blaming. As we said, you should be hard on the topic but soft in persons. By the end of the meeting, you should have an agreed plan of action, and you should have to ensure that these changes to be implemented and to agree the measures to monitor these changes. Let's look here again at our table. Let's take the second line here. So we know that the pediatricians in the first data collection, the criteria was not met because only 98% of deliveries, the pediatrician was there from the beginning. We find that it was because of shortage of staff. So what are our recommendations? The recommendation will be here, meeting with the pediatric team. So you have to allocate or delegate this task to Dr. XYZ from the obstetric department and Dr. ABC from the pediatric department. And you have to give them a probable time or a certain time to come back with the result of implementation of this change. So this is a simple way to explain how you will come out with the recommendations and how you present and disseminate this recommendation and how you implement the change and how you will monitor these changes. So till now, in the cycle of the audit, number one, you have to choose your topic, selection of the topic or identification of the problem. Then you have to set criteria and standards. And we know now what is the difference between criteria and standards and what's benchmarking. Then the data collection under Data Protection Act and 6 Caldecott principles. How to collect the data, what are the sources of the data, how we will do it, prospective or retrospective, what are the pros and cons of each way, and who will collect the data will depend on the size of the audit, either it is a small or large project. And the data analysis, how we will detect the sample size, how we will do an easy performer, and how we will do data analysis. Then you will come out with recommendations. You will disseminate this recommendation and agree an action plan and implement the change and agree the measures to monitor. To complete the audit cycle, you have to do a re-audit. Usually, the suitable time to do your re-audit will be from 6 to 12 months at least. Why re-audit is important? Because it is essential to review if the recommendations were implemented or not. If the recommendations were implemented, now you can measure if there is improvement in practice from the initial audit or no. If you are going to do a re-audit, it has to be done according to the same standard and the methodology of the initial audit to avoid any bias. The result of the re-audit should be compared to the result of the initial audit, and it should also be compared to the gold standard targets according to the evidence-based guidelines. So 6 to 12 months at least, according to the same standards and the methodology of the initial audit, and you will compare it against the national standard, and you'll compare it against the initial audit. So again, for example, if the MRCOG technique was done in 80% in our practice in the initial audit, and in the re-audit, it is 97%, but the national audit is 100%. So it means there is improvement in our practice, but still we did not reach the target. If the pediatrician present at birth, it was 98 in the initial audit, but it is 100 in the re-audit, means we now met the target of the national standard. This means there is improvement and we reached the standard. So this is a way to do a re-audit and when to do re-audit. What are the criteria of successful audit? This is the 5th question in the topic. So again, let's review the previous question. What is the definition of an audit? What is the difference between audit and research? What are the steps of the audit cycle? And now, organization of a successful audit. Organization of successful audit. For successful audit to be done, there should be a structured program with realistic aims and objectives. Don't overestimate or underestimate the problem. You should have a structured program with realistic aims. You should have a supportive environment to conduct the audits. Leadership and attitude of senior management, but in a non-directive way and involves hands-on approach. You should put an emphasis on team working, and you should support the staff and maintain regular discussions during the audit. So these are the criteria of successful audit: structured program with realistic aims, supportive environment, leadership in non-directive way, team working, and support. This is the way to have a successful audit. Now, why audits fail? Not all audits will make a difference. Changes does not always occur in audit. So you have to consider what are the reasons of failure. So let's discuss what are the possible reasons of failure. The first is resistant to change. The local professionals in the organization or the environment, they are resisting the change because of fear, because of unfamiliarity. They fail to participate because of lack of interest. They feel that's an added paperwork, so they fail to participate. So the first cause is resistant to the change. The second cause is failure to participate in an audit. The third is failure to continue or complete the audit cycle. The audit cycle has certain steps. It has to be completed and closed by the re-audit. Number 4, failure to provide supportive environment for an audit. As we mentioned before, the most important criteria of a successful audit is a supportive environment. So if you fail to provide support to the environment for audit, it will fail. Lack of resources, especially time, that's why now audit is considered as a part of clinical practice, and those involved in the audit will have time to complete their audit cycle. The next cause is lack of resources. This is the same, lack of resources, especially time. The next cause is lack of training in audit methodology and evidence-based skills. Another cause is the cost. And the final cause, the patients themselves. They may have some preferences that are against the change or that will make the change more difficult. So these are the possible causes why audit fails. Resistance to change, failure to participate, failure to continue or complete the audit cycle, failure to provide supportive environment, lack of resources like time and cost, lack of training, and the patient preferences. So this is all about the audit cycle and what you need to know about the audit before going to the station. Now, as we said in the beginning, you will have two forms of stations in the audit scenarios. Either it will come as a simulated colleague task to teach your junior colleague what is the audit, what is the different components of the audit cycle, and how to apply this on the requested task that will be usually the referral for the colposcopy or the number of cesareans that's increasing or the referral for cases of ovarian cancer. I think now all the answers for the questions that you need to do in the stations, I think it's made clear now. I hope that you will have all the answers for this station now. The second form of station in the audit scenarios will be a structured discussion where the examiner will ask you to critically appraise an audit which was done before, or he will ask you to complete the cycle of the audit by doing re-audit. So you need to know how to critically appraise an audit paper. Actually, I don't like to give you certain fixed phrases. I prefer that everyone made his own phrase, because if you will say, or if you will go by the phrase of someone else, if you forget a sentence in between, you may get confused and you will not know how to continue. But in this station, because it is somewhat difficult, I prepared some phrases here. You can take it and change it according to your style. So if you are asked to do a critical appraisal, how you will do your introduction or your intro during the station. For example, I will say, I will start by critically appraising this audit on the management of shoulder dystocia conducted for a period of 12 months by identifying its strengths and weakness, by going through each step of the audit cycle. And finally, I will conclude by suggesting any changes required in the present audit, so it helps to improve the clinical outcome while managing shoulder dystocia. This will be a good way for your introduction during the critical appraisal station. If the examiner asked you, or the scenario is a re-audit scenario, so I will go with this way. I will say, before starting the audit, I have to ensure that all the previous steps were complete and that there were recommendations from the previous audit that were implemented and monitored to evaluate if there is any change or improvement results from the initial audit. So you are completing the work, you are closing the cycle of the audit by doing re-audit. So you have to go through the steps of the audit, the previous steps, step by step. As we said, the first step is to choose the topic. Here you have to mention the importance of the article given to you, the aim of the audit undertaken, if there was a need for ethical approval or no, who was involved in the team. So a ready phrase, if you want to use it, I can say that the importance of the topic here is shoulder dystocia. It is an important topic because it is an obstetric emergency and its occurrence cannot be predicted or anticipated, as 50% of cases occur without any risk factor. This is the topic and the aim. I will add, I need to gain ethical approval from the audit department because I need to gain access to the patient details. I should involve all the stakeholders, all the healthcare professionals which are involved in the labor ward or in the delivery of the patients. So this is how to talk about the first step, which is choosing the topic or identification of the problem. Coming on your way, how to go through the second step of the audit, what are the criteria and the standards? Here, you have to mention if the sources of evidence were given, if there was inclusion criteria for the audit, and was the local protocol is up to date to the national one or no. So I will say, for example, so the next step in the audit cycle is to set the criteria and the standard. I need to know about the inclusion criteria, which will be in this audit, for example, women who had delay in the delivery of the shoulders for more than 60 seconds after delivery of the fetal head. Also, I need to know if they have chosen the MRCOG Green Top guideline on the management of shoulder dystocia as the standard to be followed for the management of shoulder dystocia, which is the national evidence here. Here, the examiner may come out and ask you what you will keep as the standard. The answer, the MRCOG Green Top guideline on the management of shoulder dystocia, and you have to mention the percentage of cases of shoulder dystocia. This will be your target. If your practice is more than this percentage, means you have to implement changes to reach or to come back to the target. So now this is the way how to do your intro to the station, either critical appraisal or re-audit scenarios, and then the steps will be the same. You have to go step by step through the audit cycle. We've finished how to choose a topic or to identify the problem and what are the criteria and the standards. So the next step will be the data collection. Here you have to give some points about or some comments about if it was retrospective and prospective. If it was justified, you have to give a comment about the sample size. If it was adequate and what you need to do to increase the sample size, and you have also to comment about the period of time defined. If the period of time defined, it was very small, especially in a small number, in a small sample number, it was better to extend the period to make the sample large. So how to rephrase it? So I can say the next step in the audit cycle is measuring the current clinical practice or data collection. So I can see here that the audit was done in a retrospective way. The data are collected retrospectively, which is easier and takes less time and cost, but it missed most of the cases, which leads to insufficient data, and this will weaken the audit result and can indirectly impair the changes to be implemented and to improve the clinical outcome. How to comment about the sample size? You can say they have defined that the sample size is all women who have shoulder dystocia, and also the time period can be extended here to enlarge the sample size to collect more data. So this is the way to comment about the data collection. You will comment about the way of collection, either it is retrospective or prospective. You will comment about the sample size and how to improve the sample size by extending the duration of the audit. Now the next step of the data of the audit is the data analysis. So here you have to comment about the pro forma. What are the inclusion criteria? You have to comment if it was there attached to the audit or no, and if it is there, was it simple? Was it involving the relevant questions? Was the shoulder dystocia pro forma felt? Was the maternal outcomes addressed? Any fetal outcomes also addressed? And if there is anything that can be added or removed, and you have to comment about the Caldecott Principles and Data Protection Act to protect the confidentiality of the patient. So how you can phrase it? You can say here, pro forma should be kept simple and at the same time include the necessary clinical information. Like in this case, whether adequate help in the form of trained staff was summoned or available, and whether maneuvers done in a sequential manner as given in the Green Top guideline. Should also involve the maternal outcomes like postpartum hemorrhage, perineal tears, which are missed in this audit. Only the fetal outcome, the only point mentioned here is none of the babies have brachial plexus injury, which is a good point. You should always mention the good points in the audit. Critical appraisal always mentions the good points, then mention what could have done better. So in this point about the fetal outcome, you can add other important points are missed, like the birth, cord blood sample, the Apgar score, admission to NICU, fracture clavicle, and availability of pediatrician. All these can be added to the pro forma. And you have also to comment about the proper documentation and incident reporting if it was done or no, and if the confidentiality of the patient was maintained by following the Data Protection Act and the Caldecott Principles. Here the examiner may come out and ask you, do you like to follow the same pro forma? Your answer here, I have to follow the same pro forma of the initial audit, but with some changes, as it is lacking many important points, which makes it difficult to analyze the data to see if they are followed by the Green Top guideline. So pro forma needs to be changed and the new audit has to be done. So this is the answer of this question. The next step in the audit cycle is recommendation. So how you are going to comment about this? You have to comment about if the recommendations were presented. You have to comment about the venue if it was clearly shown, if all target audience addressed, and if the presentation was clear, if there was any graphical presentations, the size of the paper, the font size, and the pie charts, if the references were mentioned, if the recommendations were distributed to all the staff, and how the recommendations were monitored after implementation. So how to rephrase this? You can say, another very important step in the audit cycle is to ensure if recommendations from the initial audit were implemented and monitored to evaluate if there is any change or improvement resulted from the initial audit. The results of data to be presented in multidisciplinary team meeting, which should include midwives, midwife coordinator, junior and senior trainees, consultant, and neonatologist. Recommendations are disseminated to all the stakeholders in a board meeting through letters and emails, and the necessary arrangements are made to implement these changes. So this is the way how to comment about the part of the recommendation. Coming to the final step, which is the re-audit. What are the points you have to comment about the re-audit? You have to comment about the interval or date stated, was it suitable, and if there is any change or improvement in the practice after implementing the recommendation. So how to say it? You can say, before re-audit, we have to ensure that a particular time period has to be fixed after the first data collection in which recommendations has been applied to measure if there is any change or improvement in the practice as a result of the audit, which is not done here in the audit they give to you in the station. So this is a way how to phrase it. Again, please don't take my phrases as it is. This is my way, and you can manipulate or can you adjust it according to your way. You can make it more simple for you. Here the examiner will ask you, after how long will you re-audit? We answered this during the previous slides. You can answer here, the last important step in the audit cycle is to do re-audit, to close the audit loop. Clear timing of when re-audit will be done. I mean, after how many months of a change is being implemented, is very important to complete the audit cycle, which is at least 6 to 12 months, which is not mentioned here in the audit they give in the station. So you are giving your point and you are commenting about what's given in the station. Finally, conclude your appraisal or conclude your station. You can say, so I would like to conclude by saying, to make this audit more complete and to help in improving the clinical outcomes, some changes has to be done. Like, we have to adequately collect the data, because here the missing data is more than 50% of the cases. The performer has to be changed to include adequate information on how shoulder dystocia was managed, and what were the recommendations of the multidisciplinary team meeting, what changes were implemented, and the time frame to implement these changes, and after what time period the audit will be done. So all these changes has to be done for the audit to be complete and to help in improving the clinical outcome. This is how you conclude your station. I'm so sorry, I know it was long, but I tried my best to put all the possible questions and all the possible scenarios in this type of stations. I will arrange a session where we will practice on the different types of scenarios that may come on audit station. I will announce on the group. Thank you so much for listening. I hope it was beneficial and it will be helpful. Please, if you find it helpful, please subscribe to the YouTube channel. Please share it with your friends. And the most important, please don't forget to pray for me. Thank you so much and have a good luck in your exams.